First of all, let me say good morning and good afternoon to everyone. My name is Andrea Bianculi, and I am assistant professor at eBay and also part of the GLOBE project. And I would like to welcome Anna and Sarah and all of you to this round table, which is the second round table of the GLOBE project. For those who are not aware of the project, this is a project founded by the European Commission's Horizon 2020 program. And the objective of the project is precisely to address those issues that the EU global strategy has defined as strategic. This includes issues like trade development, but also migration and global finance. And the idea is to, based on the identification of those obstacles to effective and coherent global governance, also to suggest, recommend strategies on how the EU might promote its global governance and deal with future challenges and gridlocks, and I would say with current challenges and gridlocks. And in that respect, I think that today's topic precisely talks to this, to the current challenges we are facing today regarding the impact posed by COVID-19. And more importantly, when dealing with these issues today, we will be, well, not me, but Sarah and Anna will be giving us a gender perspective, right, to understand the impact of COVID-19 on migration and health. So I am very pleased to welcome Sarah Hawkes and Anna Triandafyllidou, who will be sharing their ideas, proposals, and insights on these relevant issues and topics. But before they do that, I would like to briefly introduce them to you. So Sarah Hawkes is Professor of Global and Public Health at University College London. She's also the Director of the Centre for Gender and Global Health and co-director of Global Health 50/50. And Anna holds the Canada Excellent Research Chair on Migration and Integration at Ryerson University, and she's also a member of GLOBE Advisory Board. So for all those who are joining us today, we'd also like to welcome you, and we'd like to mention a couple of issues regarding the organization of the roundtable. So the idea is that Sarah and Anna will provide us with their insights and comments on this topic. And after their presentation, we will open the floor for questions and answers, of course. But in this case, we'll ask you to send your questions via the chat box, right, after the presentations. Also, please be aware that the event will be recorded, so your microphones and videos will be muted throughout the event. So with all this, I think we can just now jump to the table, to the round table, and I'd like to give the floor to Sarah and then Anna. Would that be okay? Okay, so Sarah, the floor is yours.
Thank you very much, Andrea, and thank you very much for giving us this opportunity to discuss the intersection between gender, migration, and COVID. And I'm going to just give you a few slides. Okay, so I just want to, what I'm going to present to you in the next few minutes is some of the empirical evidence around the relationship between COVID the infection and gender, and then think about why we see the difference. In other words, what role gender might be playing in both vulnerability to COVID and the progression of COVID once a person is infected. And then in the final couple of slides, I just want to present to you some findings from an ongoing project that we have had underway for about the past 3 or 4 years, looking at the issue of labour migrants between the countries of South Asia and the countries of the GCC, the Gulf Cooperation countries, in particular Pakistan and Qatar, and think about what the data arising from the patterns of COVID infection in those countries, how that is a representation of the issues of both migration and gender. So the data that I'm going to present to you throughout is drawn from a data tracking website that we established as Global Health 50/50 and run in collaboration now with the International Centre for Research on Women based in Delhi and the Africa Population and Health Research Centre based in Nairobi. And we set up this data tracker back in March last year, when we started to see the data coming in from national governments in relation to the health impacts of COVID, and were concerned that what we weren't seeing was sex disaggregation in the health impact data. And all of the work that we've been doing over many years and decades for some of us, looking at the relationship between sex, gender and health, we had predicted that there would be an impact of gender and sex on the pathway, the health pathway of COVID. And therefore we were very concerned not to see the national data being presented in a sex disaggregated way. We looked to WHO to be presenting this data because, of course, WHO is the site for the collation of national data from member state governments on health in relation to COVID and all other diseases. But again, we didn't see anything coming out of WHO that was sex disaggregated. So we decided to set up a data tracker ourselves, and we're currently tracking data from 187 countries that we're looking at every 2 weeks, and we're looking along the clinical pathway, essentially the testing to outcome pathway. And the reason we focused on that is partly because we are a gender and health initiative, but also because we were fully aware that there were many other organisations looking at the gendered impacts of COVID in relation to the social impacts, the economic impacts, the community level impacts. And of course, you know, we're fully supportive of all of those initiatives, but if you like, our raison d'etre is to think about health. And I think what you see on the map is the availability of sex disaggregated data within the past month that is reported for both cases and deaths. And what we've seen over the 10 months that we've now been tracking this data is that there was an initial increase in the availability of data, and that has actually started to tail off in some countries. And I think even if you're not a development economist, you could look at this map and see that many of the low and middle income countries of the world are not currently consistently reporting sex disaggregated data. So we have a limited data set along the pathway on which to think about the relationship between sex, but we clear differences. So for example, we see that men are less likely to go and get tested than women are, and that fits everything that we have known historically about men's participation in screening programs. For example, that men, when offered a screening program, let's say for hypertension or diabetes, are less likely to take that up than women are in many cases. This is a slightly old slide, so in fact the most recent data in terms of confirmed cases is that there's an exact 50-50 split as of the middle of January 2021. This slide is from early December. So we're seeing a 50-50 split in cases, so men and women equally likely to be diagnosed as a case. But in terms of hospitalization and admission to ICU, we see a very clear male bias. In other words, men are much more likely to suffer from severe disease or be diagnosed with severe disease, be admitted to ICU, and consistently have a 30 to 40% higher chance of dying from COVID or being registered as a COVID death. Again, that increased male risk does vary with the economic status of the country and with the gender equality status of the country. And I can go into that in more detail later. But just to show you that when you have this level of sex disaggregated data, you can start to see patterns. What you can't do is explain why you see the patterns. You're just observing that the patterns are there. So why are the patterns there? Well, we think there's probably a couple of reasons, one of which is that there are underlying immunological and hormonal and physiological differences between men and women at a biological level, between people with XX chromosomes and XY chromosomes, no matter how they identify their gender, in terms of how their immune system works, for example. And the clever virology and immunology people will be able to tell you that in terms of the ability of people with an XY chromosome, their ability to defend the body against COVID is actually lower than for people with an XX chromosome. And that's to do with a relationship around an enzyme called ACE2 inhibitor. So we know that sex, biological sex, explains some of the difference between explains why we're seeing some of those differences in the previous slide. But it's my job to convince you that it's not all down to sex. And if it was all down to sex, we might see more consistent patterns. But we don't. What we see is a very clear relationship between the status of gender in a country and the status of that sex disaggregated difference, or the level of that sex disaggregated difference. So within our work, we take the normative guidance from WHO, from the World Health Organization, for our definition of gender. So gender as a social construction. And we think that gender in our conceptual framework, gender operates in three interlinked ways to influence health outcomes and health equity. So first of all, it's how gender is experienced, how it interacts with other health determinants, other socially constructed health determinants like poverty or ethnicity. It's embedded within systems and organizations and structures, and it's enacted by individuals conforming to gender roles and gender stereotypes, if you like, as to what is expected of them in any society in terms of their relationship to health behaviors, whether protective or harmful. But what I want to concentrate on in the last couple of minutes is just how does that play itself out for one category of migrants that we in particular are interested in looking at. So we know that gendered migration patterns exist all over the world, and one of the reasons that we were interested in looking at the issue of labour migrants between South Asia and the Gulf cooperation countries is because it's an intensely gendered. Over 90% of the people leaving South Asia to work in the high-income countries of the Gulf and a couple of Southeast Asian countries are men, often low-skilled, undereducated, vulnerable men, young men. So when you look at the patterns, you know, what explains why we see the kinds of differences in cases that we see in some countries is it can be explained by migration patterns. So if you look at the population of Qatar, around about 90% of the population of Qatar is made up of migrants, and of that 90%, about 90% are men. So it's no surprise that one explanation of why we see a highly gendered pattern of distribution of cases in Qatar is to do with relationship with migration. What about in Pakistan? Well, in Pakistan, we've got time series data, and Pakistan, like many South Asian countries, saw an upsurge in the epidemic in their country starting in around about April, and it was predominantly a male upsurge, a male-led upsurge, as male migrants were forced back from the Gulf and Southeast Asia into South Asia. And so we saw a very clear upswing in male case rates in those countries. We see similar patterns in Bangladesh, for example, until you had more community transmission. Why are you now seeing more male cases than female cases in the countries in South Asia? Well, I think you then have to look for a different gendered explanation, and that's about women's lower access to services. So in other words, I'm trying to sort of show to you that there is a very clear pattern of relationship that between gender and migration and this particular health outcome that can start to explain why we see the kinds of differences at country level or at regional level that are captured in our tracker. And here I just want to present to you on the final slide some quotes from the interviews that we've done with key stakeholders in Pakistan, where we're looking at why is it that this enormous body, millions of men who have left the country to seek employment overseas, why are they not better protected either by the government of Pakistan or the government of Qatar? And what you see, I mean, in the first quote from an interviewee, you see a very clear explanation as to why and how migration has increased the risk of COVID amongst this group of men. It's about their living conditions. It's about them being housed 10, 15, 20 men to a single dormitory, wherein COVID spread like wildfire. The impact on them is enormous, because what we've discovered through multiple interviews and policy analysis is that essentially no sets of governments take the entire responsibility of migrant well-being and health on their shoulders. It's somebody else's responsibility. And it boils down to, at the end of the day, very few people in power actually care about this group of migrants for anything except in terms of the economic remittances that they represent in terms of inflow of money back into their country of origin. So from our analysis, from the work that we do, we would say that that is the perfect storm for how we've ended up with this very clear interaction of gender and migration contributing to the wider spread of this pandemic. Thank you.
Okay, thank you, Sarah, very much for your presentation and for your insights. I would like now to give the floor to Anna. Anna, please.
Yes, good afternoon, everyone, or good morning for me. I'm connecting from Toronto, and great to be on board. And actually, thank you, Sarah. That was very interesting. Myself a migration expert, so I don't get to hear enough of the background knowledge about COVID and health. And definitely, yeah, I realize now how important gender is and how important it is to have gender disaggregated data. And I think you very nicely kind of introduced my points in speaking about, for instance, the United Arab Emirates and the question of migration and the fact that of course, beyond biological issues of health, one important factor in the pandemic is access to healthcare, which in the case of migration relates to also legal status, relates to the provisions in each country, whether there's a public health system and what are the provisions, for instance, for people with temporary or even no status. I have a few points to make basically about the intersections between the pandemic, health, and migration. And one of them is that we have seen somehow the pandemic in relation to migration has acted as a lens, as a magnifying lens that has pointed to things that we knew before, but we were kind of either neglecting or pushing under the carpets. And so, for instance, precisely one issue is the overrepresentation of recent migrants in what is called now the frontline jobs or the frontline services or the essential services. And actually, we've been debating in the last months, almost a year now, the question of essential work and essential workers. So, because there's a lot of talk about the essential services, but oftentimes the essential workers behind these services are not very visible. But at the same time, we've had some interesting also, how can I say, public debate about how this pandemic is very much related to immigration, because not only the essential workers are frontline workers, but some of the frontline, medical scientists that have supported the development of a vaccine are also first-generation migrants. So it was also a way to celebrate the importance of migration in knowledge production, but also in the provision of services. Now, particularly as regards the intersection between gender and essential work and migrants, we see really a significant overrepresentation of migrant women in healthcare, and in particular in senior care homes of different types in different countries, but also in frontline jobs like supermarkets and other big stores that have remained open as essential stores throughout the pandemic. And while this has pointed out the importance of, particularly recent migrants in those frontline jobs, it has also pointed out to the vulnerability and to the risk of exposure that people in these jobs have, and sometimes to the poor conditions, or at least in the initial weeks and months of the pandemic, the non-preparedness of employers and of states, federal or state authorities. I'm right now based in Canada, where actually a lot of these issues are defined at the provincial level, so at the state level. So how much there was a lack of preparedness. At the same time, I think the pandemic has shown the importance of gender differences and gender inequality to the extent that these migrant working women are also main carers for their own families, and they are mothers, and the pandemic, with the closure of schools or the schooling online, has also pointed out to some important vulnerabilities and inequalities there, as migrant women would be typically found among those who had to go to work, but at the same time had to look after children who were schooling at home. And what we have found, particularly in Canada, but I believe it is true for many big cities around the world, is that people who lived in more crowded spaces and people who live in multi-story buildings were even more concerned because of the physical, organizations of this building, of the fact that you have to go into corridors where a lot of people pass, you have to wait for lifts, where a lot of people have to use, and hence this physical distancing is much more challenging than in other quarters. And what we have seen, for instance, in Canada, is that migrant households, recent migrant households or working class households, were actually more likely to opt for complete online schooling when this became available, after the summer break, because of concerns that their kids would not be exposed to the virus at school, but rather on the way to school and back, just for such how can I say, such pedantic everyday aspects of our life, like waiting for a lift and joining many other people in a lift. And while migrant women workers have been at the front line of the pandemic in their significant contribution in different areas, what we also know from the data is that they are most hardly hit by the economic recession. And actually, we have seen this term coined of she-cession. This is not an economic recession globally, but rather a she-cession. And the reason is, on one hand, sectoral. So which are the sectors that are most hardly hit? So we spoke about the essential ones, but what about those sectors that are most hardly hit? And this is typically tourism, catering, and generally, how can I say, leisure, transportation, for instance. And a lot of these sectors, so like secondary jobs in tourism, like service providers, cleaners, waiters and waitresses, people in kitchens, etc. Of course, there is a man component, there's a male component to those, but there is a significant female component. Also jobs in the retail industry, in small shops, in small restaurants, in small, businesses in more widely in those sectors employ a lot of women, and again a lot of migrant women, and these people have been particularly affected by the pandemic recession. On top of this, I think we have to see the impact of this double care burden that falls on women, and particularly migrant women, which is the one of looking after the children and the family or elderly members in the family. And that actually we know has I think in many countries, I know particularly well the data from Stats Canada, but I've followed similar data in Eurostat in looking at different European countries. We know that a lot of women have had to resign from their jobs or take unpaid leave, and that includes also highly skilled women because of this double burden, and because one of the two parents, for instance, had to look after and be at home with the children when you have children at an age that they cannot be at home on their own doing their schooling. And it has been felt, I mean, I think in many countries that keeping schools open is also an essential service, not just for the schooling and the well-being, the mental and physical well-being of the kids, but also for enabling the workforce to be at work for those who, I mean, including even for those who can work from home. Going, however, to the origin countries, I think the other thing that we see is that there is a lot of what I have called an emergency return. It's not a forced return, strictly speaking, but a lot of migrants, and I think you touched upon it, Sarah, when you spoke about the United Arab Emirates, where a lot of these temporary migrant workers have had to go back home because their construction projects were interrupted for several months, or the service industries that depend on tourism and transportation have been badly hit. And these people found themselves going back home. Sometimes they were repatriated. They had to pay for their tickets. They had to spend their savings. And these households at the countries of origin have now to suddenly face life without those very important remittances that they depended upon. And there, the role of women is again challenged for many reasons. I mean, research has shown before the pandemic of how the gender roles are changed when men are away in temporary migration, but for long spells of time, or probably repeated spells of time where they're away for say 9 months a year or for 2 years, and they come back and then they leave again. And there is a different household, and gender role balance, and this is certainly upset by a forced, what I call an emergency return, which is not a voluntary return. In addition, there is, I mean, the main source of livelihoods is taken away, the remittances. It is unclear when people will be able to go back to those jobs. And women have to find ways of catering for the whole family, and this is where I want to come back to with the notion, I mean, with a positive note, concluding my kind of commentary with a positive note. And this is, however, where we see the importance of gender aspects of resilience in women trying to find alternative jobs, whether including informal jobs or petty trade, or petty, handcrafts on arts and crafts, or catering from the home in providing for households. And we've seen that also in the destination countries among migrant women, providing different forms of self-help, or of different households getting together to provide help for one another, whether this is in the form of delivering groceries to your neighbor who is elderly, or sending your child for groceries, or providing care for other people. And we are seeing there, I would say, also an opportunity in terms of migration policy in the reconsideration of all these jobs that were previously considered as low skill, low pay, low prestige, and kind of disposable. So the workers were considered to be disposable in the sense that, okay, there's always people who need work, and if some people are unhappy with those jobs, we'll get different ones. And suddenly we realized that this is not a sustainable migration regime, and this is not a sustainable migration system. And we have really to provide both for improving the living and working conditions of people employed in these sectors, but also to think of what could be a sustainable migration and care system that can brace up for adversities like a pandemic, but also can provide better service in normal times. And I think I'll leave it at that and look forward to the discussion.
Okay, thank you very much, Anna. So thank you both for these very interesting insights into the intersection between COVID and gender, and the differences when it comes to the impact of this crisis in terms of migration, health, and now other issues came up as you were presenting your ideas, your commentaries, as it is the case of working conditions, right? Now, I'd like to take sort of a step forward because you have sort of portrayed what the situation is, right? So there are several challenges ahead. So I was wondering, what could a gender-responsive pandemic response look like at the global and the national levels, but maybe also at the regional level, right? So thinking that the GLOBE project is more focused on the EU, what would be a regional response, what should be an adequate regional response based on a gender perspective, right? If we think the regional of this as this meso level between the national and the global levels. You decide who wants to go first. I mean, we can keep the order, we can do it the other way around. Just, I leave it up to you.
Okay, Actually, I wanted, because maybe it relates to my last comments. I just wanted to say that I think, gender responsive pandemic response for what concerns, also migration and gender perspective, I think would include retraining. And for instance, we are starting with a colleague here a project that we call Pandemic Kitchen Stories. So we're looking into those people who have remained unemployed or underemployed in the wider restaurant and catering industry, and looking at what could be possibilities for retraining and reemployment, because we realize that the tourism and, for instance, the restaurant, etc. sector will take time to go back to normal. It's not because initially, I think in spring and summer, we all thought, okay, it's going to be an interruption of a few months, hang on in there, take your emergency benefit, and things will improve. And I'm not sure, of course, that we have yet the answers of what this retraining could look like. So in the short run, because I think the more skilled people in the industry, for instance, have already tried what could be tried, like, doing small businesses of catering from home, the so-called lunch kits and dinner kits, and kind of cook for your family kits, because you cannot even have a party or a reception of any kind. But I think what, for instance, policymakers are looking at is facilitating retraining and qualification recognition in the wider care and health sector. And in countries, for instance, like Canada, there is a huge underutilization of the skills of migrants who belong to the wider health and care sector. So there is speeding up of the processes of recognition of medical qualification, use of international medical, so internationally trained medical personnel, what is called bridging programs, so helping people qualify as care workers, what is called here senior care workers, and then bridging programs for them to have a career path to registered nursing, so that people would also see the point of getting into that career path. And the other I think area that's very important is that of sustainable circular migration systems. What I think this pandemic has exposed is that in many parts of the world there is temporary and circular migration that was kind of well, researchers have often criticized those schemes, but they were seen to work to the extent that, I don't know, men from Nepal and Bangladesh and India go to the Emirates or go to Malaysia work, send remittances back home in countries like Nepal, where remittances account for 25% of their GDP, and it's a win-win-win, so to speak, a triple win policy, but we see it as not, and that we need to see how such migration has an impact, a more lasting impact on households at origin or on countries at origin in terms of improving their livelihoods and building something sustainable, not just consumption, not just improving, of course, the basic tenets of life of the household at home, but building something that is more sustainable. Of course, these are probably high hopes that might be forgotten, and I want to conclude this answer by saying that, you know, in global migration governance, we've had the global compacts voted in at the end of 2018, and suddenly we're faced with a different world. These compacts were voted and were thought of, and were, even if you want, contested in a different world. And this is really an open challenge, and I'm not sure I have yet a good answer to that, of how are the global compacts fit for purpose in this post-pandemic world, or in this pandemic world, and what can be done to use them in good ways, in creative ways.
Thank you. Yes, Sarah.
Yeah, thank you. I'm just going to stick to the health system and the health sector, just because I'm afraid it's all I know. And I think, I mean, to address your question as to what should be done at regional and global, or potentially even national levels, I mean, along that pathway that I showed you, you know, people who are at risk of getting a disease or an infection, all the way through those various steps to, unfortunately, the outcomes that include death. There is evidence for the gender responsiveness of interventions that could be implemented at each step of the pathway. And so I think, you know, and that would include, for example, vaccine development that takes into account not just that there are these biological differences in the way people's immune systems respond, but also that there are uptake differences between men and women. There are clear skepticism differences between men and women. You know, what we're seeing from surveys in Europe and the US right now is a clear gender-driven vaccine skepticism that is much stronger in women compared to men. So what's that going to mean for vaccine uptake moving forward? Are we going to see a much greater vaccine uptake in men compared to women, etc.? So, you know, it's kind of along all of those steps of the pathway, there is evidence that that taking gender into account will make a difference. You know, that if you ignore gender, or if you ignore any of the other socially constructed determinants of health, which includes migration or the intersection of gender and migration, that all of your best designed programs will never be as effective as you want them to be if you ignore the social, political, economic context within which people live their lives. So I don't think it's an absence of knowing what to understand why people don't do it in the first place. I think it's an area where we as researchers haven't spent enough time trying to understand what the motivations for gender responsive policies, programs and practices might actually be, whether that's at global or regional or national level. So what we see sort of in the broader domains of our work is that the question of framing can be extremely important in terms of how and why issues get taken up. And one of the things that we are grappling with as far as gender and health is concerned is what's the most, is there just one effective frame to have gender responsive responses, or do we need a frame that varies from level to level, region to region. So, you know, what we've seen, for example, we review 200 organisations in the health sector every year for their gender responsiveness. And what we've seen is that the private sector responds very well to the notion that gender equality, it makes your company more efficient. You know, at the end of the day, that's what they're responding to. And they put in place some policies and guidelines that respond to gender inequalities on the basis of improving efficiency. Now, that may not be a frame that works very well in sectors that are more driven by social justice and equality, and that are more reliant upon the idea that gender equality is a human right, and therefore we should be responding to gender inequality as a violation of human rights. But I you know, I think that we ourselves need to be much more politically astute about what we're asking for across levels and sectors when we put forward notions like gender responsiveness. Because I think the other thing, just to finish, that we've really clearly seen is that when you say the word gender, it means different things to different people. You know, what we've clearly seen in the health system and the health sector is that when you say the word gender, what people hear is women. And they design policies and programs for women and girls. And of course that's necessary, of course, nobody's denying that. But I think what our data shows is what we all instinctively also know, that gender is everybody. It's not just that 49% of the population that self-identify as women and girls. So if we're truly gender responsive, we need to understand what people are themselves think gender means, and why they don't all respond to it on the basis of the vast evidence base that's already out there.
Okay, thank you very much. Shall we open the floor for questions from the audience now? So please, those who are in the audience, remember that your microphones are muted, so it would be great to get your questions through the chat box that you can find at the bottom of the screen. I have more questions, but I think it's a great opportunity for you to ask Anna. Okay, here we've got that one from Louis Schmidt. Are you reading the question, or shall I read it? So his question is mainly, what is holding governments back from releasing sex disaggregated data on COVID? And he wondered whether it is this is because they are lacking technical capacity. Is this a political decision, or is it that they are not aware of the importance of having such data?
Yeah, I think that's probably true. So I think the most generous response I could give is that it's a case of benign neglect rather than overt neglect, or an overt decision not to present it, except in one case where we know it is an overt decision because they've written to tell us that it's exactly that. So I think, just to be clear, that what we collect somebody who spent, you know, the best part of 30 odd years working inside health systems, I can tell you that it's impossible for me and my colleagues to imagine any health system in the world where when you enter into a hospital or a primary healthcare system or a mortuary, that somebody doesn't fill out a form to say that you are male, female or other. In some countries, but somewhere somebody will have ticked a box to say you're a man or a woman. And particularly when you die, not to put too fine a point on it, somewhere on your death certificate, everywhere in every country in the world, it will say whether it's a man or a woman that's died. So it's not an absence of the data itself. The data is definitely there inside all of these systems. It is an absence of the willingness or the thoughtfulness to pull the data together and to present it. And that, I think, boils down to the medical and health professions not recognizing that sex and gender have an impact on health outcomes. For Western medicine, the history of Western medicine over the past 2,000 years has been a system that has been built on understanding the notion of the male default body. Right. The idea that there is something other than the male default is something actually incredibly new to health research. It's only in the past 35 years that NIH has mandated that clinical trials must include women, for example. Prior to that, all clinical trials could take place just with men. So we're struggling against a very strong historical imperative that completely overlooks the roles that sex and gender might be playing in driving health outcomes. So the systems have the data there, but inside people's heads, they don't think the data is important. So I really think it's a case of benign neglect from the people running the systems. What surprises us is that from week to week, we see countries that report the data one week and don't report it the following week. So I find that more astonishing, that somehow some is making a decision every week to neglect it or to include it. I honestly can't explain why that's the case.
Okay, thank you very much. Any other questions or comments from the audience?
Which was the case of overt neglect. You know what, I'm going to tell you, it was Public Health England who wrote to us and said that they didn't think sex was important as far as COVID was concerned. So they decided not to report the sex disaggregated data consistently.
Okay, well,
yeah,
that's nice.
And I guess that reflects back to my first set of comments that we all think it's important, otherwise we wouldn't be spending an hour on this fantastic session. But it's why is that message not getting through to the people in decision-making positions? How do we frame it to make people pay attention?
Yeah. Okay. Any other question or comment from the audience? Okay, so I think I have a question for Anna based on what you mentioned at the very end of your comments. You mentioned that the global compacts were thought of and contested in a different world, right? So based on this diagnosis that you have made in terms of migration, COVID, health, etc., what would be your suggestions to move forward, to change, to adapt, to contest the global compacts? Because they were only established, not even 3 years ago, right? They are so new.
Yeah, actually, I suppose not everyone is aware in this webinar, so I'd like to say a few things. So what the global compacts were negotiated and eventually signed in December 2019 in Marrakesh. And then for the refugee compact, where the work was led by UNHCR as the main convening actor, there was a provision of annual consultations, and the first annual consultation took place in person in Geneva in December 19. And there was online consultation this year again. For the migration compact, actually the migration compact, where there is no single convener, but it's rather a working group where the IOM, the International Organization for Migration, provides for the secretariat, so to speak, supporting the work of this working group that includes 9 UN agencies and other 30 UN agencies that are less involved, plus bilateral, multilateral consultations with a range of actors from civil society but also, for instance, from the private sector and of course from different countries. So this compact has 4 years, I'll say it a bit colloquially, to get their act together. So it has 4 years to come back with a consultation. So one wonders, how will this 4 years shape the next steps? I think what emerges right now, I think, is with renewed emphasis, is what I said before, to rethink what is a sustainable migration regime in particular world regions, and exposes the vulnerability of a system that is, well, actually taking advantage of people's needs to migrate and make some living without providing any conditions for a next step of a migration that improves the situation for the migrant and the household at origin, and also the country at origin. The other thing is, for instance, and I think that relates very much to what Sarah said about health systems. So right now what we know is that the vaccines are bought by the more affluent countries. And we have heard, and maybe I'd like to ask Sarah to reflect on this, because as we are watching, the vaccination levels in different countries, and Israel has vaccinated 44% of their population. And I read an analysis about it by a scientific journalist, not a researcher, who explained the different elements of this recipe. So obviously one element was a public health system where they could track people and invite them to get vaccinated. That the military took over a lot of the implementation because they have the capacity, that cities collaborated very importantly to set the vaccination sites, and that Israel offered themselves as a laboratory for Pfizer to see what is the level of immunity that the vaccine is offering in a country that is relatively small, 9 million people, is not geographically dispersed. For instance, like say Canada or Russia or Australia or even New Zealand. And Israel was ready to pay 3 times the price for the second big load of vaccines that they had to cover. So, they started strong, but as the vaccination field was crowded, Israel came in and paid 3 times the price. So I'd like to hear from Sarah if this is a good account of what happened with Israel, or what are her reflections on this. What this raises is the question also that there's been this pledge for global vaccinations for the less affluent countries, and for what concerns me, the countries of origin of migrants. But we haven't seen this very much taken priority right now, as we all in the more affluent countries are competing to buy the vaccines. And here in Canada, as I was telling you, the opposition was really last night blaming the Prime Minister for not putting enough pressure on the pharmaceutical companies, and et cetera, et cetera. But I speak a lot with colleagues from places like, as I said, Nepal or Bangladesh, but also Nigeria and Ghana and India, and what they tell me is life goes on as normal. Yes, universities are online, but if you go out in the market, people are out and about, because the dilemma is one between, making a living for basic needs rather than, being worried about your health from COVID. And the question then that arises, of course, in terms of migration governance is, we've heard talks about airlines requiring vaccination to let you on board. Some countries, including my own country of origin, proposing a health passport to facilitate. The idea is to facilitate transport and tourism and business travel. But we see that this can have a really discriminatory effect. And anyhow, it is a double-edged sword. And the question that arises is, again, to give an example, because these last weeks I've been working a lot on South Asia. So if Nepalese workers are ready to go back to the Emirates and construction recommences in the Emirates, and actually the Emirates are, I think, second or third in the top global list for vaccinations, will they have access to vaccines, or will vaccines be part of an employment contract? Or if the Mexicans are ready to come back to the US and Canada for agriculture, will this be the same, and how will this be governed? So anyhow, I mean, so I think I have more questions than answers, but I think these are important issues, and it is great to have Sarah here to provide for that aspect of the discussion.
Okay, so Sarah, would you like to react to Anna's question on Israel and vaccination?
Yeah, I mean, to be honest, I don't know the story of what happened in Israel in a huge degree of detail, actually any more than you've just described, Anna. We must have seen some very similar reports here in the UK, but I think that what you're describing, it is one of from our perspective as people who look at the global health system, one of the hugest challenges of global governance that is being faced right now is how we are going to ensure social justice and equity lie at the heart of vaccine distribution. Because what we're really, really clearly seeing right now is countries' self-interests coming to the fore. So what we've seen is the establishment of COVAX, which is the global financing facility for access to the COVID vaccine to be universal, based on every country having a fair crack at the whip and being able to vaccinate. I think it's 20% of their population based on vulnerability within the country itself. But alongside that, what we saw, what Dr. Tedros, the head of WHO, put out last week was a figure that in all least developed countries combined, low-income countries combined, a total of 25 people have been vaccinated. That's 25 people across all low-income countries. So the COVAX, one of the problems is that COVAX as a global facility is essentially running in parallel to countries' own national interests. So whether you're in Canada or in the EU or in the UK, what you've got is countries fighting for their own populations whilst also nominally putting money into COVAX. But when it comes to negotiating with pharma, what you've got is countries operating individually. And, Israel and others are incredibly illustrative of that. And I think, from our perspective, what this suggests is that if you leave this kind of negotiation to member states and countries, you are bound to get this level of self-interest. Within my lifetime, this is not the first time we've seen that level of self-interest in the scale of a global epidemic. And I think that there's really important lessons for us all to learn in terms of what happened in HIV. And we need to look back at the role of civil society demand for access to the vaccine and not rely on weak governments negotiating with powerful governments to have access to very expensive products produced by the pharmaceutical industry. At a global governance level, we've got the TRIPS flexibilities. We should be absolutely putting those into play right now to ensure that
I think
we lost.
Yeah, we missed the last part, Sarah, but I guess we all agree with you on the relevance of civil society, right, as a driver for governments to buy or to produce vaccines, right? Because I was thinking of HIV and I was thinking of the cases of Brazil and India being very prominent actors even at the World Trade Organization when it came to intellectual property rights, right? And this is something that we're not seeing today in Brazil, right?
that was exactly what I mentioned, was TRIPS flexibilities, I'm amazed that we haven't had a greater demand for TRIPS flexibilities. And some of it may be that there simply hasn't been time for civil society to get itself organised. Because one of the differences is if you get HIV, it's not an immediate progression to, people live with HIV for many, many years and did way back in the 80s, lived with HIV for many years and could fight for their rights. Right now we're in absolute crisis mode. And so it's not necessarily civil society that is infected with COVID, but it is going to rely on the civil society affected by COVID, which is all of us, to demand a global response rather than these national or regional responses to ensure equity. Otherwise, we're going to end up in situations where you've got high-income countries with half the population vaccinated and the rest of the world left absolutely to their own devices. And that, whether you're a global governance scholar or not, that cannot be the fair and just way forward.
It's not even viable because what also the pandemic has shown is we knew the interdependence of countries on all aspects, but the pandemic has again been a magnifying lens. And you mentioned the case of the United Arab Emirates. Can the Emirates function without migrant workers? I don't think they can. But that is also true. Canada is very aware that Canada needs immigration, and I think even in Europe, there's less of public acceptance on the part of governments of such a discourse. We know this is the case. So, it's
it's a very engaging topic, and I guess because this is going on now when we are sort of living and studying it, everything at the same time, and trying to come with suggestions and recommendations. I'd like to put forward a question by Ursula Ahrens, who's asking if there is available data showing if girl migrants are impacted differently from boy migrants when it comes to access to education, healthcare, etc.
Actually, I had seen the question. I didn't answer because I haven't seen any data as regards destination countries. I don't think there's a special impact that goes beyond health and what Sarah showed us. I don't know. I have to admit I don't know about origin countries, but I think in terms of origin countries, I think, as I said, that right now the issue is again that comes back with new relevance is the question of return and what is called return and reintegration or sustainable return. And I think there already there was quite some discussion, because sustainable return for countries of destination means that people will stay there and not remigrate, but that's not necessarily what is sustainable return, because I can return, have a good return in the sense of finding a job, finding my place in my country of origin, but still want to remigrate because I have good reasons to do so. So I think, yes, the pandemic will prompt us into into the need of looking more closely at what return is and what reintegration is, and how to deal with that and in relation to remigration. But I think what you also said, Sarah, is very important in terms of the HIV pandemic. That was a kind of more slow and ongoing for years, and that has an impact on civil society. I'm afraid, although I'm generally a very optimistic and positive person, right now I believe even civil society is not there yet, because we are in emergency mode. Get us the vaccine now, and no one thinking, okay, getting the vaccine ourselves is not sufficient, and not just even for selfish reasons. Even for selfish reasons, getting the vaccine in different countries is important for the functioning of the global economy, not just for social justice. So a world that is divided into yet two groups, I don't know, 20% of the population vaccinated and 80% not, is not viable.
Mm-hmm. Okay. Are there any other questions or comments? okay, because it's already 4:05. I think, this has been a great roundtable. I really enjoyed chairing the roundtable. This has been a very interesting debate. So I would like to thank you both again for your contributions to this roundtable, for your participation. And I would also like to thank our audience for joining us, for their questions, for their comments. And I do hope we get a chance soon to go on talking about these issues, which will be on the global governance agenda, at every level, right? And I would like to end with this comment of taking gender into account. This is something that we cannot do without, whether at the national, regional, international, global, but not even only for health, right? But for policies more generally, I would say. So I don't know if there's anything you'd like to add, Sarah, Anna. If not, we can leave it here.
Thank you very much. Thank you, Tina.
Yeah,
thank you.
Thank you
both, and thank you to all the participants.